Hi, how are you? I'm with Dr. Franz Weidinger from Austria. He's an interventional cardiologist and the past president of the European Society of Cardiology. He's with us today at the Congress of the Society, of the Argentino Society of Cardiology, and we are very glad to have you here.
Thank you very much for the invitation. I'm glad to be here.
Okay. We are wondering. We just came from your presentation of the guidelines of chronic coronary syndromes, and as an interventional cardiologist, what do you think about the invasive versus conservative therapy strategy in these kind of patients?
Thank you for this important question. I think over the time we see that the invasive approach and revascularization is becoming maybe less and less justified and applied in chronic coronary syndromes because we have many potent event-reducing medications. So if we are consequent in establishing the right medical therapy to these patients, we do see a decline in the need for revascularization and more invasive approaches. And I think the guidelines nicely show the recent evidence that supports such a careful approach.
Thank you. Yes, of course. And what do you think of these patients when they have all the medical therapy they can get and they still have symptoms? What is your approach? Do you prefer to do an anatomical study or you go to dyschemia?
Good question. I think when I look at the patient, the symptoms, if it's typical or atypical, it's not recommended to use that any longer. But if you have a very symptomatic patient with several risk factors for atherosclerosis, then I, as an interventional cardiologist, tend to have a low threshold to a transradial invasive coronary angiography because it's a very quick procedure, and then I have 100% diagnostic security of the diagnosis. So that's my own approach. But I think if the patient is not too old and if we have a good radiology department, I think coronary CT and either calcium scoring or with CT angiography is a good way to rule out coronary obstructive disease and to talk to the patient and say, okay, you can be calm. Okay,
thanks. And about when you choose to do angiography, do you have problems to use FFR or intravascular ultrasound or OCT?
No, we have that available, and we do use it, but only when we are not sure about the angiographic significance of a stenosis. Then we use FFR to really make the choice of whether to do PCI or not. And also, when we guide complex PCI, of course, we like to do OCT and or intravascular ultrasound to guide the procedure.
But not to decide in a chronic coronary syndrome, the IVUS or the OCT, about treating or not a lesion.
That's a good question. If we have a proximal LAD when we are not sure whether it should be whether it's significant or not, then we may do FFR also in chronic coronary syndrome, especially if the patient does not have clear symptoms. Okay. So in that case, we do FFR also in CCS patients.
Okay. And the penetration of the intravascular imaging in Europe in general and in your practice in particular?
Well, we don't do it very often, but we have clear indications. So, okay. For example, in acute coronary syndromes, of course, we look at the non-culprit lesions in a second procedure and then do FFR and to decide whether to also revascularize non-culprit lesions. In the CCS setting, as I said, we don't do it very often, mainly to guide complex PCI procedures.
Okay, thanks. And talking about another issue of another INOCA, what is your approach in those patients?
if I see a patient with clear symptoms and then I do invasive or non-invasive CT angiography, not seeing much, then I would choose to establish and begin medical treatment. Start with anti-anginal drugs, vasodilators. I think that, beta blockers, of course, address the demand type of ischemia. But vasodilating drugs, I think nitrates should not be forgotten, long-acting nitrates, to see whether the patient improves on vasodilating drugs, also calcium channel blockers. If the patient improves, then I would probably stop and not do more because I have already done invasive angiography. But regarding the new recommendation to actually prove vasospasm or endothelial dysfunction with acetylcholine infusion, there is a surprising, very high recommendation, class 1. And I'm really interested in seeing how this will be implemented because, as we know, this is invasive. It's an intracoronary infusion of acetylcholine with different protocols, high dose, low dose. So it takes time, and I think we really have to be careful in choosing an invasive approach for something that can be treated medically and not with either surgery or PCI.
Okay, what about when we because not so long ago we do it a dichotomic way to understand patient. If they have microvascular angina, for example, they can't have epicardial. Mm-hmm. What do you think about that?
That's a very important point you raise, Matthias, because these two entities can overlap, of course. And if we see many patients with persisting angina after successful PCI, we know that as interventional cardiologists. Sometimes we are frustrated and patients are frustrated. They come back to us and say, "Doctor, what should we do?" Then you're right, we have to think about the microvascular component of the disease. And maybe the new guidelines show us more possibilities how to reassure the patient that it's not so dangerous, that we can try more medications to relieve symptoms on the one hand. And if really the patient still has symptoms, then we may want to choose this invasive approach with acetylcholine to really look where is the real problem, at which level of the microvasculature. So I think that would be a rational approach.
Okay, not to be invasive at the beginning, only if it's necessary.
Only if it's necessary, okay. Exactly.
And the last for me is what about secondary prevention when the anti-inflammatory drugs? Where is the place? I think that it's my opinion. When you talk about colchicine, for example, for life?
Mm-hmm. Good question. I think we don't have enough data to answer that. But if I have a patient who has every event reducing drug, lipid lowering, and so on, still has symptoms, still comes back with an event, maybe need for revascularization or a small non-STEMI, then I would consider adding anti-inflammatory drugs. So really to do everything that has scientific evidence to further reduce the risk of recurrent events in those patients.
Okay. So one last one. What about the clopidogrel place now is instead of aspirin or as aspirin? It's only the host exam, the trial where we support that data. We need more data.
I think we already have enough data to say, okay, if we like to replace aspirin by clopidogrel, we can do it as a single agent. I don't think it's imperative. It's absolutely necessary to change. If the patient tolerates aspirin, we can continue. But clopidogrel does have a good role for also prolonged dual antiplatelet therapy in some cases, but also as a single agent if the doctor and the patient agree to do that.
Okay, thank you very much for your time. It's a pleasure and an honor to have you here.
Thank you very much also.
Muchas